Yeah.
Thank you, sir.
Yeah, please go ahead.
I would like to invite Dr. Ghanshyam Patidar to say a few words regarding the CME.
Thank you, sir. And on behalf of Ratlam IIP, sir, welcome to all of you. And sir, myself, Dr. Ghanshyam Patidar, is working in a civil hospital, Javara, since 16 years here. And our strength is 21 members. Yeah, and our secretary is Dr. Utkar Jain, and our treasurer is Dr. Devin Shah. Hello, are you getting all of you?
Yes, yes.
Yeah. And I joined.
मैंने अभी खाई है ऐसे रुकी.
Yeah. Hello. Yeah, since I as elected as a president, so 5 activities since then we have done. Academic activities in January. I would like first role of nebulized respiratory therapies in management of respiratory disease by Amit Kushwa from Ratlam. And on 20th Feb, CME on pre-referral management and golden hour management, Dr. Jafar Khan and Dr. Pragya Dubey ma'am. And on 15th March, CME on antenatal diagnosed fetal anomalies by Dr. Hemant Jain and by Dr. Pratyush Jain. On 10th of April, skin and soft tissue infection by Asim Sharma. Yeah. And on 24th of April, role of prebiotics by Dr. Utkarsh Jain. Yes. It's all by the time since I was elected as a president, the 5 activities, academic activities done, sir. And regularly we will, in future, definitely, we'll continue all these things. Yeah.
Good. Yeah.
Very nice, sir.
Thanks, sir.
Now I would like to invite Dr. Gaurav Mongra to start the proceeding of that one. Dr. Gaurav. Dr. Gaurav, are you there?
Gaurav is mute actually.
Yes, sir.
Yeah,
Yes, sir.
Gaurav.
Just a minute. I'm sharing, sir.
Yes.
Hello, good evening, everyone. So today's our CME is basically on the vitamin D. So coming to the topic, so vitamin D is not only used as a drug in the endocrinological disorder. It has actually vast implications. So today we will be discussing about the indication in the uses of vitamin D, and our speaker for today is Professor Dr. Mahesh Maheshwari. He is a professor of pediatrics and pediatric endocrinology at AIIMS Bhopal. He currently holds the position of Central Zone Joint Secretary at IAP Medical Education Chapter. He is a member of Research and Guidelines Development for the Pediatric Endocrinology. He has past positions of IAP President of MP IAP, as well as he has held multiple positions, including the CIP member from the MP and other. He is also associate editor of IAP Pediatric OSCE Masterclass book, as well as he has the 35 publication in various index journals. And today, experts for our session will be Dr. Ankita Maheshwari. She is a pediatric endocrinologist from Indore. She is professor in the pediatrics department at Aurobindo Medical College, as well as she is a consultant endocrinologist at various hospitals in Indore as well as Bhopal. She has also a lot of publication in the index journals, and she has written the chapters in books. Dr. Vaishnavi Agrawal, she is pediatric endocrinologist again from Indore. She is consultant at Vishesh Jupiter Choitram Hospital, and she is the trainer for non-communicable disease for the NHM, and she is also co-author for thyroid module, which is published by the Indian Society of Pediatric and Adolescent Endocrinology. And Dr. Pavitra Nagaraj, she is from Bangalore. She is a pediatric endocrinologist. She is associated with the Mazumdar Shaw Medical Center at Narayana Health City in Bangalore. So I welcome all the speaker and all the experts for this session. Thank you very much.
Sir, can you start now? Dr.
Okay.
Gaurav?
Should I start sharing my screen?
Yes, sir.
Okay. My screen is visible?
Yes, sir, it is visible.
Okay.
Sir, please put on slide share mode.
Make it full screen, please.
Yeah. Okay. So am I audible and my screens are visible?
Yes,
Yes,
go ahead.
yes, sir.
Thank you. So at the outset, I thank before taking my presentation in next 30 to 35 minutes, I thank Honorary President of MPIAP, Dr. Rajiv Sanghvi sir, and then Dr. Dinesh Mekle, the Press Secretary of MPIAP. I'm really thankful to the team who taken forward the program which I started during my MP IAP presidential tenureship. Dr. Rawat sir and his team is really working very hard, and they are selecting the topics that is really useful for the general pediatricians, for medical students, and for the medical college teachers also. I'm This is really a nice initiative to involve these younger branches. So Ratlam IAP, Dr. Ghanshyam and Dr. Mogra is definitely working very hard. And I think I seen 4 CMAs in 4 months at a smaller town is really a remarkable achievement. So I congratulate Ratlam
Thank you, sir.
branch for this. And I am really happy to see my experts in this particular panel. My dear friends, my colleagues, Dr. Pavitra Nagaraj, whom we are working since almost 4 or 5 years at various platforms and various forums of Indian Society for Pediatric and Adolescent Endocrinology. Dr. Ankita, she's a very close allied colleague of mine at various places. Dr. Vaishnavi, I'm happy to share that Dr. Vaishnavi did the fellowship with me only at All India Institute of Medical Sciences and really doing well in Indore at this point of time. So, and the respected teachers and the faculties, I am able to see Dr. Rashmi Dwivedi madam here, and this shows that how much this program is actually appealing to the to the pediatricians. So, the topic which was given to me is vitamin D, evidence-based guidelines for its use in children. Just like Dr. Naveen Mogra said that Dr. Mogra said that there is a role both in vitamin D deficiency related skeletal problems and at the non-skeletal problems also. So it's really a very important topic in present scenario when we talk about. So vitamin D, as all of us know, is a prohormone that is essential for calcium phosphate homeostasis. How it functions and where it functions, it primarily functions at the skeletal, that all of us know that it helps in bone mineralization and primarily prevent the rickets. That is the one common clinical condition that we see in our day-to-day practice. There are evidences that is evolving this role in immunomodulation. So that is an extraskeletal effect on infectious causes and non-infectious causes. We will talk about a little in subsequent slide in the later half of my presentation, that how it is going to work out, what is the role of vitamin D in these particular conditions. Deficiency of vitamin D is many of the time is subclinical and that will remain underdiagnosed. We usually advise the vitamin D for some other conditions or maybe with the skeletal problem only, and then we turned out to be a vitamin D deficiency. It's now in a country where we are saying that vitamin D is primarily made from the sunlight and we are living in a tropical countries, but still this is a major public health problem in our country in spite of the abundant sunlight. So what is the epidemiology? We know, all of us know that epidemiology wise, probably our country is not having that much data that is available. But the last data that was published by the Comprehensive National Nutritional Survey in 2016 to 2018 on that data, this guidelines, various guidelines were made. This says that toddler in the age group of 1 to 4 years, almost 40% are deficient. 18% of the children between the age of 5 to 9 years of school age is deficient. And in adolescents, surprisingly in adolescent, the 24% of the adolescent between the age of 10 to 19 years is actually the deficient. And there is another important thing that we need to remember, and this survey suggests that in adolescent, out of this 24%, 34% of the adolescent girls are deficient compared to only 14% of the boys. And I think all of us know the reasons behind this major gender difference in this particular thing. There are many extensive studies were done in India, especially even in Kashmir Valley, showing almost 83% deficiency of vitamin D. It confirmed that the abundant topical sunlight does not equate with the clinical sufficiency, necessitating the proactive management. So we can say vitamin D deficiency is actually, there is no demography that is spared. All the age groups, especially in pediatric population till adolescent, it is affected. So when we should say vitamin D deficiency, all of us, just like I said, there is most of the time there is no clinical feature that is suggestive of vitamin D deficiency. So you always says on the basis of vitamin D level. So there is no international consensus on the threshold for serum to vitamin D concentration for general public and general health. Various guidelines given various cutoff to define the vitamin D deficiency in nanogram per ml. This you can convert in units also, and you can convert it in the nanomole also. So Endocrine Society says that the deficiency is less than 20 nanogram per ml. In consensus with the and the insufficiency is between 21 to 29, and the sufficient is more than or equal to 30 nanogram per ml. Global consensus says that there is a 12 nanogram, less than 12 nanogram per ml is deficiency, 12 to 20 nanogram per ml is insufficiency, and more than 20 nanogram per ml is sufficient vitamin D. IAP revised guideline, we are primarily focusing on the IAP guideline. There is a toxicity cutoff is also given. More than 150 nanogram per ml as per the Endocrine Society is a cutoff. For global consensus, it is more, and IAP consensus, it is more than 100 nanogram per ml associated with hypercalcemia or hypercalciuria. In our setting, we are actually believing following the IAP 2021 diagnostic cutoff. This says that this is very important whenever we are seeing the reports of vitamin D. So anything that is less than 12 nanogram per ml is deficiency. 12 to 20 nanogram per ml is insufficiency. More than 20 nanogram per ml is sufficiency. And more than 100 nanogram per ml, actually the toxicity, if it is associated with hypercalcemia or hypercalciuria. Why we chosen less than 12 when the Endocrine Society is saying less than 20? Because we are primarily focusing on skeletal outcomes over the undefined extraskeletal benefit. At this point of time, there are not many evidence. There is evolving evidences, but not many evidence that there is a really extraskeletal benefit is also there. So to avoid the over supplementation in our country, we taken this cutoff and we are strictly cut it off to less than 12 as an deficiency. How to estimate the vitamin D? I think whenever we send the vitamin D estimation, there are two methods. One thing is the immunoassay, automated immunoassay. That is we usually send to the lab. It's a very simple method, less expensive, and require a low sample. So it is a very preferred method in the pediatric population. It is affected by the total body protein. So whenever you are evaluating or whenever we are interpreting vitamin D level in this particular children, you need to see the total body protein level at the same time. It cannot differentiate between D2 and D3. That is the disadvantage. And D2 is more in infant, so it is not a reliable method. So whenever we are sending the vitamin D level in infancy, we should try to send with the different method, that is the liquid chromatography ultraviolet rays or liquid chromatography mass spectroscopy. That is the preferred method when we are really thinking that there is a vitamin D deficiency and we want to treat without any symptoms. So a little bit about the vitamin D metabolism. All of us know that the skin is the primary place where the vitamin D is synthesized. So there is an ultraviolet B light between the 290 to 315 nanometers converts 7-dehydrocholecholesterol into the pre-vitamin D3, which isomerizes to cholecalciferol. And this, in the presence of 25 hydroxylase or CYP2R1, it is first hydroxylation and change it into the calcidiol. This 25 OSD normally is the primary storage form, and this is the clinical parameter that we utilize in assessing the vitamin D deficiency. Then there is a second hydroxylation occur at the level of kidney, and this is 125 1-alpha hydroxylase, and this will result in 125 hydroxyl 2D. This is an active form of vitamin D, and that regulates the calcium and phosphate. Why it is important to understand at this point of time that what is the first 25 OSD and what is 125 OSD, because when we start thinking about the treatment, we should know how it is going to work in that scenario. Now there is some dietary reality. Whenever we talk about, we will say, "Aap dhoop mein khade ho jaiye," you take some sun heat, you eat good milk, you take eggs. This is that will take care of the vitamin D. So there is no need to supplement the vitamin D. If you take various guidelines of what is the recommended daily intake for vitamin D, Indian Academy of Pediatrics, ICMR, and European Society for Pediatric Endocrinology suggest that the recommended daily dose of vitamin D is 400 international unit. In various variable age groups, we will take it all infants and children. So what is happening to our diet? This is the data given by the published in 2017. This says that unfortified milk has a very negligible vitamin D, that is 8 to 24. So that is one glass of milk only provide 8 to 24 international unit of unit per liter, and this 27 one egg will give the 27 to 40 international unit. And the most richest source is actually the fish that has the maximum amount of vitamin D available. But in our country, where almost 54 to 56% of the Indian children is actually on the vegetarian diet, making the natural dietary supplementation or sufficiency is nearly impossible. So we can't rely completely on the food supplements. So dietary reality is that it's very important to understand that you really require a lot of quantity to provide the sufficient requirement of vitamin D, that is 400 international unit per day, by giving diet. So diet alone cannot do it. So what are the factors, especially in consideration to our country, for vitamin D deficiency? When we talk about the sunlight, the ideal time is between 11 a.m. to 3 p.m. And most of the schools in our country is functioning between 11 a.m. to 2 p.m. Then they remain in the indoor area. So there is a duration of timing of sun exposure is not that much. Amount of skin exposed, there is a limited body surface area exposure due to the cultural practice about the public modesty in our country. There is a atmospheric pollution also plays an important role. There is an Asian brown cloud cover due to the many industrial pollution, and that will result in less proper sunlight. Skin pigmentation, India requires 3 times more sun exposure due to the high melanin content than the normal other Western population. So sunscreen use is nowadays is very common, especially in an adolescent age group, that is the most affected area. If you use a product that is having a SPF of 8 and 15, it almost prevents the decrease the vitamin D synthesis by 95 to 98%. Then dietary habits, I already told, our primary diet is having high phytates, fibers, phosphate, but in low calcium, and multiple times boiling and deep frying, and all these conditions actually cause the more availability of vitamin D through the diet. Then increased consumption of aerated milk. We are, instead of taking milk and other things, we are not taking more of aerated drinks. Prolonged breastfeeding. Some of the communities having a prolonged breastfeeding. Some of the communities having actually not the prolonged breastfeeding. So there is a poor content of vitamin D in breast milk. Genetic factors also plays a very important role. In our South Asian countries, there is an increased conversion of 25 hydroxy to 24 with the help of 24 hydroxylase, and it will convert into the inactivated vitamin D. There is a changing lifestyle. We are living, because of urbanization, we are preferring more of indoor environment, and especially in this type of summer, many of the people are inside. Emerging epidemicity of obesity, that is again a very common scenario in our population. Vitamin D sequestration in body fat, so they will require more vitamin D. And there is a myth regarding vitamin D. Sun exposure is sufficient in the morning and evening. If you hear the older people, they will usually say just go in the morning for 1 hour or 2 hours, that is sufficient enough. There is no need to remain in the sunlight for a longer duration. So now I think the question comes, once we know about the physiology and what is the need, and when we will say vitamin D deficiency, the prevention of vitamin D deficiency, how can we prevent that? So there is a various ways. So maternal supplementation, is it helpful? maternal vitamin D status and maternal vitamin D supplementation has no bearing on the anthropometry outcome and bone density of the offspring in infancy, but definitely it will affect the biochemical vitamin D deficiency and prevent the neonatal hypocalcemia. At this point of time, the universal vitamin D supplementation is not recommended during pregnancy, but definitely they require a normal RDA to maintain the normal vitamin D level and the prevent hypocalcemia in neonate or infant. What are the guidelines says it for infants, that is between the 0 to 1 year? All of us writing in our day-to-day practice now, there's a universal supplementation is required. How much? 400 international unit per day. It is safe for both term and preterm. There is no need to give the additional vitamin D in a term or preterm. The guideline says 400 international unit per day. The rationale is breast milk is actually a very poor source of vitamin D and complementary feeding usually lack fortification. So this is the reason we need to supplement till the age of 1 year. Some people use the higher doses, but there is no added advantage of any skeletal benefit or risk toxicity will increase more. So this is very important message for a general pediatrician I am interested in giving. Don't use 600 or 800 or 1200 international unit in the infancy because there will be more chances of risk toxicity is there. What we can suggest in what guidelines says for older children and adolescent, in more than 1 year, there is no routine supplementation that is recommended in this particular age. The target you can acquire by just 400 to 600 international unit per day by through sunlight and diet, because more than 1 to 5 years probably you're not going to school, maybe it will help. And this also helps that it will prevent unnecessary medication of healthy adolescent. So, and screening the asymptomatic children is explicitly not recommended by almost all the guidelines and especially the Indian Academy of Pediatrics. So just for a routine sake, when we are writing the routine investigation, we should not write the vitamin D estimation in each and every child. So that has to be avoided. How can we prevent? How much we need? So the general measures is you need to require minimum 17 to 30 minutes, not much. It's only 17 to 30 minutes in infants or 30 to 45 minutes in older children of sunlight exposure. And the minimum exposed area should be 15 to 40% of the body surface area. And what is the peak timing? I already talked about. The peak timing is between 11 a.m. to 3 p.m. at least 5 times a week. So there is no need to stay whole 7 days in sunlight. Even if you stay 5 times in a week for this much of duration, that is sufficiently provide the vitamin D to the body. So diet, and at the same time, you need to take the diet rich in natural sources of vitamin D and adequate calcium. Encourage the outdoor play and physical activity and identify and manage the high risk children, especially the chronic illness and malabsorption. So just like I said, there is no need to advise vitamin D estimation in each and every child, but there are few conditions when you need to advise the screening for these particular children. So there is a targeted screening that is required, especially in a high risk clinical group. So if a child is having a non-ambulatory state, we are seeing many neurodevelopmental cases nowadays. So cerebral palsy children or any neurodevelopmental disability that is not able to find out the proper diet or proper sunlight exposure, chronic kidney disease, where there is a problem of related with the metabolism or biosynthesis of vitamin D. At the same time, again, the additional requirement you cannot fulfill from the outside, chronic liver disease, malabsorption syndrome like celiac disease and cystic fibrosis. There are children who are on a long-term medication, glucocorticoids and anticonvulsant. These are the two common medications prescribed by pediatricians, and endocrine disorders, especially the hyperparathyroidism. There are some more where you need to require the screening for regular screening in these particular children, and routinely supplementation is indicated in these particular condition, not in general population. So a little bit about the nutritional rickets. I am not go in detail about nutritional rickets. This is not the topic that is related with this particular on this particular topic. All of us know that the primary pathogenesis is hypophosphatemia that is driven by the parathormone. It's prevent the apoptosis and unmineralized cartilage result in different clinical features that what we usually see the white plate, white, cupped and frayed metaphysis. There are clinical features, rachitic rosary, bowing deformity, and the weight-bearing bones. Sometimes they present with the hypocalcemic seizures and dilated cardiomyopathy. Investigation-wise, the baseline investigation is the alkaline phosphatase. And elevated parathyroid hormone will confirm your diagnosis that probably you are dealing with the nutritional rickets. Then how to approach a child with the nutritional rickets? So any child who is presenting with clinical features of rickets, you need to first see, is there a red flag sign? So the red flag sign, if there is a family clustering, that means there may be few more members who is having a clinical feature suggestive of rickets. There is a history of consanguinity. Then there is a CKD, CLD, malabsorption, alopecia, polyuria, or failure to improve on prior vitamin D. These are the few red flag signs. If these red flag signs are there, start thinking you are maybe dealing with a non-nutritional rickets and evaluate for other specific causes. Again, I am not going in detail. So parathormone, vitamin D, electrolyte, urine creatinine ratio, renal ultrasound, these are the investigations that require. If there is no red flag sign, assume that this is a nutritional in origin. Only investigation that you require is calcium, phosphorus, alkaline phosphatase, and wrist X-ray. And in some scenarios, you may go ahead with the parathormone. Otherwise, these investigations and the clinical picture is sufficient to make a diagnosis of vitamin D deficiency ricket. You need to start treating this particular rickets. We will talk about treatment in the next 5 to 10 minutes. Is re-evaluate after giving the treatment at 12 weeks. If there is no change in the biochemical or radiological, switch to the non-nutritional evaluation path. So this is the way you need to approach. Now I come on to the treatment. I think this is among pediatricians, this is again is still a debatable topic, though these guidelines were published in 2021, published in 2022 and prepared in 2021. And then since 2016 guidelines also causing the international guidelines is giving almost the same thing. But still we are not able to follow it in a generalized way. So in less than 6 months, if there is a rickets, you need to give 2000 international unit daily and till 12 weeks, and then give the maintenance dose 400 international unit daily. In between the 6 to 12 months, you need to give 2000 international unit daily. Intermittent is not preferred. So first 6 months, it is strictly no. 6 to 12 months, it is not preferred. What guideline says, we usually follow that till 12 months, we should not use the STOS therapy. And more than 12 months or adolescent, the daily dose is 3000 international unit daily is preferred method. Sometimes you can give this 60,000 international unit every 15 days for 5 doses. So fortnightly you need to give it, not every weekly. 60,000 international unit fortnightly for 5 doses, and maintenance dose is 600 international unit per daily. So this table is very important to learn. At the same time, whenever you start vitamin D, you need to start the co-supplementation with oral calcium. And oral calcium is 50 to 75 milligram per kg. Maximum dose when you give with vitamin D is 500 milligram per day. So and how to evaluate this particular pointer? After 4 weeks, you can perform the radiograph to look for early evidence of a healing line. Absence suggests there is a non-nutritional etiology. So whenever you start the treatment and you really want to follow up, there is a classical rickets, you can go ahead with an X-ray. After 12 weeks, you can start with the complete radiological healing. Check serum, calcium, phosphorus, alkaline phosphatase, and vitamin D. Post-healing, you need to continue this maintenance dosing for at least 1 year. Now there's some words about what is the difference, what is the efficacy and evidence related with daily versus intermittent therapy. So as a pediatrician, we always think whenever we write daily, patient usually don't take it for a longer duration, and ultimately he will not improve. So what are the advantages and what is the science is saying? So there is a major pediatric studies done and prove that low daily physiological doses is highly efficacious in healing rickets during infancy. It actually mimics, so this is a gold standard, is actually mimic the natural cutaneous synthesis and safest metabolic profile, and there is a zero risk of hypercalcemia. I think zero risk of hypercalcemia. Whenever you use the STOS dosing, that means the doses we want to give fortnightly, the 60,000 international unit, in a child where there is an erratic compliance or erratic population, then you can give this STOS therapy, but there is an inherent risk of hypercalcemia. And again, I am re-emphasizing, it should not be recommended for infants under 6 months at any point of time. Which formulation we should use? So there are both the formulations are available, vitamin D2 and vitamin D3. Preferably, we use vitamin D3, that is the commonly available. Most of the pharma companies usually come up with the vitamin D3 is a preferred. It's an animal or UVB derived origin. It has a longer half-life, produces greater, more sustained increment in circulating 25 OSD, and ensures the accurate lab monitoring. So this is the reason we need to prefer. Calcitriol is a active vitamin D. Sometimes people use the active vitamin D कि जब मुझे देना ही है तो मैं active vitamin D क्यों ना दूं? But it usually the bypasses the physiological regulatory checks and causes the toxicity. So it only reserved for hypocalcemic seizures, or there may be a specific condition that is there. The preferred route is oral. Only one indication where you can use the IMA uses when you are having a proven malabsorption and you want to give the vitamin D. There only there is a roll-up intramuscular injection. Otherwise, there is no roll-up intramuscular injection. Last 3 or 4 slides. I think I will finish it within time. So now everybody is talking about the extraskeletal health. So what extraskeletal health evidence says are there? So in extraskeletal, we says pneumonia is more common, tuberculosis is more common, HIV is more common in vitamin D deficient children. So there is definitely most of the time we are getting, because they are associated with malnutrition also. So we are getting this vitamin D on a level on a lower side. So it correlate significantly with this particular condition. But in reality, whatever the studies are available, the routine supplementation has no beneficial role in pneumonia, in tuberculosis, in HIV. So in these 3 conditions, it is definitely not recommended. Now there is an emerging evidence for diarrhea. We are talking about zinc. Zinc, again, there is in some changes that low dose of zinc came down. So people are thinking about vitamin D also in recurrent diarrhea or in diarrhea patients. If this is not a malabsorption syndrome, there is a poor correlation with the severity. And supplementation is not beneficial in acute childhood diarrhea. Maybe in chronic diarrhea, because of that, maybe because of malabsorption or secondary malabsorption, because of the acute chronic persistent diarrhea, there is some role of vitamin D that may come, but otherwise there is not beneficial in acute diarrhea. Extraskeletal health, you can talk about asthma and atopy is also there. So there is a lower levels are found in these particular conditions, but supplementation does not protect against exacerbation or improved atopic dermatitis. Whatever studies are available, what they are doing, most of the thesis we usually give, we see the vitamin D status in this particular condition. And the result is that there is a deficiency or insufficiency of vitamin D in these particular children. But there are very few studies that is comparing or there is RCTs that is doing finding the effect of vitamin D on these particular conditions. Obesity or metabolic condition, again, the routine supplementation does not improve the weight outcome. So there is no change. You should try to maintain more than 20 nanogram per ml on an individual basis. So there is definitely the requirement is little more. So you may give it. There's this people are talking about autism. That is one important condition nowadays. Everybody is trying everything in these particular conditions of vitamin D. There is a higher incidence that is associated with vitamin D deficiency. But primary reason is these children don't play with the other children outside. They are not exposed to sunlight. They are taking the food as per their wish. So this is the reason there is a deficiency of vitamin D. But is there really a therapeutic role? It is not very clear till now available studies. Maintain the optimal status. That is the most important thing. One clinical condition where there is a role was suggested. Other which we are seeing normally is the nephrotic syndrome. In nephrotic syndrome, routine vitamin D and calcium supplementation is actively recommended due to the loss of binding globulin and steroid use. The target serum is somewhere again more than 20 nanogram per ml that we need to keep it. The Indian Academy of Pediatrics guidelines suggest to use it. I think right now one of my PG is doing thesis on this particular topic to give an RCT on this particular topic to give vitamin D in first dose or not to give in the first dose, because till now the recommendation primarily for the relapsing nephrotic syndrome. So if there is a frequently relapsing nephrotic syndrome, definitely it needed to be given. But we are trying to find it out. Is there a role to keep this vitamin D level maintained in first episode of nephrotic syndrome? So I think the last 2 slides. So there is an toxicity. Again, there is a picture, comes in picture because we are using the vitamin D here and there in each and every child. So there is a therapeutic
vitamin D पे था.
have increased. So the incidence of toxification is there. When to suspect toxicity. So if your level is 50 to 100 nanogram per ml is highly unusual without supplementation. So you usually don't see this vitamin D level at this point of at this level. So I given vitamin D, someone again supplemented vitamin D without taking the past history, and that will result in there may be a possibility of toxicity. So 50 to 100 nanogram suggests toxicity. The biochemical marker is you need to do the vitamin D. We are doing. You should do the perform a PTH, and that PTH distinctly suppressed in the 2 toxicity. And how will we confirm? So you need to confirm because the Indian guidelines and the global consensus says there is an urinary calcium uh, criteria is important. So if the urinary calcium excretion is more than 4 milligram per kg per day or age specific elevated spot calcium creatinine ratio, this is toxicity that you need to think of, and then you can send to the pediatric endocrinology. So this, I thought I will go in detail about this, but just to save the time, and I think there are very brilliant experts with us in this particular forum. So they are going to give their comments on this particular thing. So the guidelines, there's some changes with the global consensus and Indian Academy of Pediatric guidelines. So I'm not going detail. I already talked with these pointers in my previous slides. So the last but not the least, take home messages, the silent epidemic. So you need to start thinking about vitamin D deficiency. It is rampant in India across all ages, despite abundant sun. The last survey was published in 2016-18. It's almost 8 to 10 years. And the reason, the factors that is causing vitamin D deficiency is actually worsening. So there will be a more chances of vitamin D deficiency. You need to follow the strict definition to just to over medicalization. So very clear, only treat when there is a deficiency, not for the insufficiency. Whenever you are finding insufficiency, always try to ask them to do the other parameters, that means diet, sunlight, and other things that you can plan it out. D3 is superior, physiological doses you can give it. Or the calcium caveat, vitamin D cannot heal the bone alone, so always give calcium with this. And the calcium doses is 50 to 75 milligram per kg, maximum 500 milligram during the rickets therapy. Target. So the last message is target vitamin D deficiency detection, but don't troll. Never screen healthy children. Reserve testing and prophylactic dosing for only high risk population. So I think I'm little faster just to keep the time and give an additional time to my experts and their expert comments. So I will stop sharing here, and then maybe if there is some questions.
Thank you very much, sir, for an enlightening talk. And probably there is no question in the chat box. I will come to the questions later, but at least you can put your questions till then. So I will move to the experts now on comment about the vitamin D therapy. So Dr. Ankita, you are muted. You are muted.
Am I audible?
Yes, yes.
So thank you, sir, for such an enlightening talk. I think sir has covered most of the topics and he was very clear in his talk. So sir has highlighted it very well that routine estimation of vitamin D is not required. So we should not waste money on that. And calcium supplementation is as important as vitamin D supplementation. Sir, although I just have one comment, rather query, that they say that daily dosing is preferable over intermittent dosing. But the practical problem arises is we don't actually have a preparation that gives 3000 international unit of vitamin D. So we are not left with an option other than giving boluses doses of 60,000. So what's your comment on that, sir? Sir, unmute.
Dr. Vaishnavi vouch on this because we had a lot of debate on this particular topic in our days when she was here, because many of the times in OPD, with especially the OPD that is coming to the government setup, because in a private setup, when the patient comes, we can definitely explain, even the volume is more, 5 ml to 2000 international unit is available, and there is an other smaller nano doses are available. So definitely those smaller bottles finish very fast. So that is one other problem. So practically it is really very difficult to plan, but you need to decide on the basis of patient to patient. And because I also took it every quarter, fortnightly, but every fortnightly my wife used to tell me, "Aaj vitamin D ka day hai, aapko dhyan hai." So I think that is also equally difficult to maintain that. So it's almost equal. So I think it's depend on the patient to patient basis. You can decide.
Sir, one more thing. Recently, we had an international consensus on vitamin D deficiency in 2024. I think you must be aware of that. So, Endocrine Society of India was also a part of it, and many societies. And they say that you have to empirically supplement all children right from 1 year till 18 years with routine vitamin D. 400 international unit in infancy and 600 in 1 to 18 years. So, but IAP doesn't, IAP in the guidelines are very clear. So, should we do that or should we not?
So if you see the 2016 guidelines, even those guidelines is also suggesting a little bit on that side, not 100% on that side. But as an Indian Academy of Pediatrics and as an Indian population, what we are talking about, we are in the habit of either taking everything as a blanket statement. So I think all of us now we are writing the vitamin D in neonate. That is the one prescription that is there. Now we are started playing with the doses, because something extra or additional we have to do it. So some started writing 600, some started writing 800, and companies also coming up with those particular smaller studies. So similarly, so this is the reason we are primarily focusing on the skeletal benefit at this point of time. In pediatric population, there are not many studies that is having a non-skeletal manifest effect of vitamin D. So this is the reason we usually say that there is no need to supplementation at that particular age. But if you are seeing a high risk patient, or even the activities you are noticing that the child is going to the school, not playing with that kid and all those things, even the scenario you can take it, your threshold little on a higher side. Rajiv sir.
Yeah, I just wanted to ask one thing. Since this probiotic, prebiotic things came, so everybody was using it, each and every disease, as you name the disease and the people were using it. Nowadays, a lot of studies are coming up when there are people, they are using it in ADHD kids or in type 1 diabetes also. And they found out that if you supplement these with vitamin D, the outcome is very good. So I don't know how effective it is in ADHD.
No, sir. No, sir. Whatever the studies available till now, though there are not very smaller RCTs, very smaller studies that is there. So definitely this is a field where you need to still find out the evidences and learn it. At this point of time, probably not.
Yeah.
But just to add a point on
Yeah,
this,
Dr. Pavitra, you can.
sir, you were talking about vitamin D in type 1. Why are they supplementing is there was a study in France where it said that vitamin D deficiency has caused type 1 diabetes. That is the reason maybe everybody wants to supplement vitamin D in type 1, but that was only one study on that. But after that, we have no studies which says that vitamin D has caused type 1. So
Okay.
there is no evidence after one study, sir. So I really don't think that is the reason for type 1.
Okay. Thank you. Thank you very much.
And I think not in the progression as well. It doesn't prevent the progression as well.
So there are few questions I think I can ask with the expert. So Dr. Pavitra, there is a question how RDA can be 400 international unit in all age groups.
No, sir, first, all the expert have to give their comments.
Okay. KG US, sorry.
So, Dr. Nagaraj, please.
Yeah. So the other comment what I wanted to make is many of them come to me where they have given IM preparation orally. So please do not make this mistake. IM preparations are for IM injections, oral is for oral. So it doesn't get absorbed when we give IM orally. So many of the pediatricians and the practitioners give IM as oral. So please do not make this mistake. As sir has rightly mentioned, IM is preferred only in malabsorption and not routinely. Just because you see single digit, it doesn't mean that we have to give IM. Single digit also, oral will be sufficient. The second thing is, sir, you mentioned fortnightly, but there are no studies which says that daily vitamin D or weekly vitamin D has caused hypervitaminosis. So It doesn't mean that giving fortnightly will not prevent hypervitaminosis. It can cause if you're treating unnecessarily, as Sir has rightly mentioned, do not give vitamin D in everybody. It is like one era is for vitamin D, one era is for calcium, magnesium, selenium. Now there is magnesium everywhere in the market, in on Insta, on social media. So I think every year they come up with new supplements, and we just fall prey to that. I think we should avoid. Mahesh sir has given an excellent overview of where to use, when to use. I think we have to take this message home.
Dr. Vaishnavi.
Thank you. First, I would like to thank all the esteemed members of MP, IAP to give me this opportunity to be on the expert panel. And thank you, Mahesh, for such a informative, like always, lecture where you get to learn everything from basic to finish. I would just like to add, because this has been coming and because of popularity of social media channels and Instagrams where the health to tell of supplementation of vitamin D without knowledge. I think that is all the illusion modulation that it might do in autoimmune disorders, and also because of the high prevalence of vitamin deficiency, like sir pointed out, because of our darkly pigmented skin, dietary intake is also poor, and sun exposure is also poor because clothing and all. So yeah, matlab, there are some large RCT that have been like vital for that example, which have showed that there is no real uh, benefit in giving routine vitamin D supplementation in all age groups. It is just for selective age groups who have high risk for osteoporosis or fractures, or postmenopausal women, or in pregnancy. And the doses are very well told by Mahesh sir in his slides. So yes, selective screening and selective supplementation is the key. That is it. Thank you.
Thank you very much. So now the questions. So the first questions which we have got is how RDA can be 400 international unit in all age group, because the skeletal growth differs in different age group.
The experts, Dr. Pavitra, are you giving the
Yeah.
answer?
Yeah. So see, it is not about the skeletal maturity. If you see, it is not only vitamin D which is required for skeletal maturation. We also need calcium and phosphorus for the skeletal maturation, which that differs as the age grows. The RDA of calcium and phosphorus is different from vitamin D. So the absorption is the same irrespective of all the age groups, and that is why the RDA remains the same in all the age groups. So remember, it is not just vitamin D which is required for skeletal maturation. However, they say that as in childhood, you might require a little more, like 600 to 800, but the minimum RDA is 400 for all age groups.
Okay. The second question was, the calcium supplementation is recommended only for treatment of rickets, or has to be given with routine vitamin D supplementation in infancy? Am I audible?
Yeah.
Yes, yes.
Dr. Ankita?
I think routine supplementation in infancy is not recommended. And what they say is at least in the diet or in milk, if they are getting 50 to 75 milligram per kg per day of calcium, that is enough. Even in older children also, they say that if you're getting a minimum of 500 milligram per day in diet, in milk and other sources, then routine supplementation of calcium is not required across any age group.
So I agree with Dr. Ankita. I think calcium is sufficient in the breast milk to give the this particular. So there's no need to aid it. Even the 50 to 75, what we are talking is quite less from the RDA, because we are definitely getting more from the food and the other items. So there's no need to additionally supplement that. Dr. Guru.
How can be exposed in sunlight from 11 a.m. to 3 p.m. in a very hot weather?
So the duration is very short. It's only 40 to 37 minutes. So if you get up at 11 o'clock, maybe you can go, but you can't go at 2 o'clock. So if it is really needed, but obviously you need to change it, and you don't need to do every 7 days. 5 days in a week, that is sufficient enough. So if you take it in that way, maybe it is sufficient enough. And
Yeah, during school days, it's during the lunch hour is when they can get exposed.
sports activity.
Sports activities or lunch hour is the main where they have half an hour between 11 to 3. Lunch hour is the best way they can get exposure to sun.
Dr. Sonika, I think
I will try it from tomorrow.
yeah.
So what we usually do at hospital is we go for chai at 11 o'clock so that we get some exposure to sun. Otherwise, we are always inside the AC and all our vitamin Ds will be in single digit.
So Dr.
Yeah,
Along with
that's
that,
true.
we should not use sunblock cream at that time.
Yeah.
Yes.
So
So the next question is, in preterm VLBW NICU graduate, what is the maintenance dose 400 IU or more?
Same. Same.
No, I would differ then.
Dr. Gaurav, अपने comments बताइए.
Then I would differ. I would differ then.
I think in slide sir had mentioned that you can give 400 or 600. There is no additional benefit as per the studies of 600, but you can safely give 600 in preterms. I think
So we routine. Okay, then that there can be a discussion.
So actually, these are what the guidelines is suggesting based on the basis of studies available till now. Whatever the systematic review and meta-analysis was done. Nowadays, there are many studies which is in picture or in pipeline where they are using a little higher dose for those particular children, just like in the non-rickets condition. So maybe within some time, the more literature will be available and we will be better able to answer. But
many NIC protocol suggest कि preterm BLW graduates में हमें थोड़ा higher dose में approximately 600 to 800 internationally देना है as a maintenance dose.
Sir, 600 to 800 भी नहीं है. It is very right now the protocols do suggest for the neonatology. I'm not talking about the endocrinology. That 800 IU per day is the standard protocol for the preterm babies. It is there.
So
and it is followed like since 10-15 years probably. So is it correct or it is not?
So at this point of time, I think the guidelines and the studies is not really much supportive. There are few studies that suggest that higher doses will be, and there is a non-inferior study, so there is no toxicity. But is there really any added advantage? That was not there.
That's true. I think sir had made it a point that giving 600 is not causing the harm to the infant. But yes, many studies have not commented on the benefits either.
We are giving 800. We are not giving 600.
You are not causing toxicity anyways, but this is what the guidelines say. The endocrine.
Okay.
We are a
Okay,
little
so then,
on the
okay. So we'll move to the next question. Sir, other than rickets, when to ask for vitamin D levels routinely?
It's not routinely. I told already there is a high risk conditions where you need to usually advise. Okay, there's one more study we are doing at this point of time is the vitamin D treatment with vitamin D in growing pains. I think that is the one other condition where many of the children are coming to us with growing pain, and we usually write in one children we write calcium, in one child we write vitamin D and calcium, in one child we write vitamin D, and in some we'll say just give plenty of fluids. So there is no studies available at this point of time. We are doing one RCT at this point of time on this particular topic also, but only I am able to see only one study that is saying that there is an advantage of giving vitamin D even in growing pains. So as such, and that is not a very big study, there is only 80-90 patient, but that was the only proper study that was done. So at this point of time, high risk conditions is the only conditions where you need to advise the screening for the vitamin D. CKD, CLD, malabsorption, all those conditions.
Other than rickets, when to ask Okay, sorry, this was done. A dose of vitamin D in older children in case of deficiency.
So 3000 international unit, daily 3000 international unit, that what the guidelines also suggest. But again, the problem what Dr. Ankita has already talked about, giving 300 means you have to give at least 10 ml or maybe 7.5 ml that in that particular child. So 7.5 ml daily with such a small bottle, with that particular bottle, there's only one or two company that comes with that such large bottle. So, but still we can use it.
Nowadays, 1 ml containing 2000 international unit preparation is also available in the market.
But that is very small vials.
That is on
Those box will finish in then very few days.
There is a risk
Hey,
of
Parents
high dose
usually think the box is
administration.
finished, not a single bottle.
single bottle is available around 10 ml bottle सर नया आया है जिसमें 1 ml में 200 2000 international unit आ रहा है सर आजकल तो
Dr.
we
Mohammed,
recommend for the maintenance की just give a 1 or 2 drop for 400 international तो उसको हम यूज कर सकते हैं.
Okay, so next question. When vitamin D deficiency is at subclinical level, why should it not be used in prophylactic doses?
again repeat your question.
When vitamin D deficiency is at subclinical level, why should it not be used in prophylaxis dose?
So insufficient. So that means you want to say the child is having insufficient vitamin D. So if there is a insufficient vitamin D, you can refill that particular that deficit by your diet, by your sunlight exposure. That is okay enough. So there is no need to really treat with vitamin D. Prophylactic vitamin D is not needed.
Okay, so next question. Is there any study to prove role of vitamin D in asthma?
Again, there are very few studies, and I already told there is not
Observational
much
only.
benefit.
No large RCTs are available, only observational studies.
So, Dr. Gaurav, can I just intervene? I think Dr. Rashmi Dedi madam is here since beginning. If madam want to give her comment.
This was the question was from madam only.
Mahesh, I was just thinking
Yes,
to
ma'am.
set points. Okay. One was use of the first question that I asked was that vitamin D deficiency is mostly at the subclinical level in children. So
Yes.
that my query was because if you think that every child is having a subclinical deficiency which is not manifesting, then should we get a vitamin D level done or should we give a prophylactic dose? That was first question. Second question that I would like to ask is diarrhea. I don't think is has been vitamin D use in diarrhea has not been recommended in most of the studies or it may help. In fact, vitamin A is something which acts on the epithelial cells. That is why most of the systemic diseases, whether it is respiratory, abdominal, or any other thing, there vitamin A will help and zinc will help. But vitamin D is a prohormone, as you said. It has its action on the skeletal muscle. So it will help only for the skeletal muscle. And third thing that I would like to put in is that we should also suspect vitamin D deficiency in children who are having delayed gross motor development. Because most of the time these children are not having their proper supplementations also. And delayed developmental, I have seen 2 or 3 cases just last week where it was vitamin D deficiency because the child was not being fed properly. So this is one place where you should get a X-ray done, as you said, X-ray disc done or whatever. And I just got the X-ray disc done and alkaline phosphatase and I gave a vitamin D supplementation. So these are the 3 observations that I would like to put in.
So very rightly said, ma'am. I think the global consensus and the endocrine society also suggests in the same that you can give the prophylactic doses in children also. That is one thing. But in Indian Society Academy of Pediatrics usually just to avoid the over medication, we usually don't suggest to use it as a prophylactic medicine. That was the basic reason. Not many evidences. The evidence is not that strong not to give the prophylactic at the same time. Second thing. what you said about the gross developmental delay, I think you are very absolutely right that sometimes this gross developmental delay may be the only clinical presentation as a early rickets or maybe the vitamin D deficiency. So definitely you need to suspect, keep your threshold little on a higher side in this particular condition. Vitamin A in diarrhea, physiologically you are absolutely correct, but probably I also need to check a little bit about the studies available for in that sense.
Another thing that I would also like, that is my clinical observation, is vitamin D deficiency and rickets, specifically the earliest sign is increased perspiration overhead, which is the first sign. If you ask the mother, when the child sleeps on the pillow in the night or whatever time, does the pillows feel wet? That may be the first sign of vitamin D deficiency in infants less than 1 year.
Thank you. Thank you, ma'am. Dr. Gaurav, I think Dr. Sonika ने hand raise किया था. अगर if you are not finishing with just on time.
टाइम अप हो गया सर.
Sir, I have already posted my
एक question
question.
और है.
Okay.
Yeah, the child has gone in insufficiency because of the legs exposure to sun, and as the sir explained, very minimal IU available in dietary supplements. So why not to correct at this stage so that the child doesn't lead into deficiency, as low sun exposure and all are actually not very practical these days.
But we can definitely ask the school authorities to make it their playing period somewhere between round about that particular period of time, at least not in summer, but at least in the other days, other months when primarily summer, most of the children is not going to school since last almost 15 days. I think more of the mothers can understand their presence at home. So that is definitely indicated. In that way, we can ask the authorities and the food products. Probably we need to increase our diet supplementation by just taking the high vitamin D sources. But practically, again, many of us are vegetarians, so that is sometimes create a lot of question. So other than milk, not many things that you can take as a vitamin D rich source.
So, sir, that's what I was asking. Is there any harm if we, like, in the investigation we find is there is an insufficiency in child's blood investigation? So, is there any harm in giving supplementation?
Over
Just a
medication
question.
should be avoided. It should be patient to patient, and depending on that, how much they follow your advice.
Okay. Thank you, sir.
Sir, 30 minutes each day for 5 days versus 3 hours in a sunlight on 1 day. Is there is a difference?
I will do the RCT.
New topic. So I think we are done with the questions, Dr. Gaurav.
Sir, just one more. Sir, we give 60,000 IU per 5 ml, 0.5 ml alternate day for 3 months instead of 3,000 IU per day. So I have to make the calculations right now.
These are more of an
So
hypothetical.
60,000 per 5 ml means 12,000 per ml. 0.5 ml is 6,000 unit alternate day versus 3,000. So 6,000 units alternate day versus 3,000 unit per day.
So again, these things probably they are not studied in that minute manner. So all these things are still possible. So you can't say exactly no, this is not feasible. But definitely the moment you start increasing the doses, there will be a possibility of hypercalcemia and toxicity. So you need to be very careful whenever you are doing this type of study. So sometimes you need to stop those studies in between if there isn't some complication that starts happening. Any other comment from Dr. Ankita or Dr. Vaishnavi or Dr. Pavitra?
I think so. We can give, sir, because it's mentioned in the guidelines also that you can add the cumulative dose and give like that. But the only thing is your patient should be intelligent enough to understand this. So he should only consume 0.5 ml alternate day. That is a bit difficult.
Overdosing can easily occur, and I do not know if we can monitor that very well, especially in busy OPDs. So I think we should stick to what guidelines say for journal dictum, and obviously according to the intelligence of your patient's parents.
I think theoretically it is right, but practically I don't know how feasible it is.
They shouldn't
last
land up
question.
taking more dose just because they missed one day. They
Yeah.
shouldn't be taking instead of 0.5 1 ml because they missed one day. So that
just
happens with our smart parents.
Even
Just to
smarter.
summarize, I think when I shown that particular slide, when to why the IAP kept the guidelines of less than 12 as a deficiency, not less than 20. I think that summarized the whole story, that we kept it a cutoff in a country like us where we don't want to over medicate the child. So because that is the only reason why we kept it a little stricter cutoff. Otherwise, the cutoff is 20 in most of the guidelines. So if you are giving on a little on a higher side, not a big issue. But at the same time, you need to assess at the patient to patient basis.
So the last question of the day, sir, duration of treatment in deficiency.
So 12 weeks, obviously, we in rickets we usually give it, and the normal maintenance we need to give it at least for 1 year.
आई थिंक अभी और कोई क्वेश्चन नहीं है, और मेरे लैपटॉप ने भी बोल दिया है लो बैटरी.
Let me take over.
Thank you very much.
Excellent discussion. On behalf of MPIAP, sir, should I go for vote of thanks, Rajiv sir?
Yes, sir. Please go ahead with us.
Yes. So on behalf of MPIAP, first of all, I would like to express our sincere gratitude to our expert faculty, Dr. Mahesh Maheshwari sir. Sir has a very enlightening presentation that enriched all of us. I also thanks our expert, Dr. Ankita Maheshwari, Dr. Vaishnavi Agrawal, and Dr. Pavitra Nagraj. And special thanks to Dr. Rasmi Dwedi madam for their expert comment. I extend my heartfelt thanks to Dr. Ganjam Patidar and IAP Ratlam for hosting this session. I also acknowledge the work of our scientific committee led by Dr. Rawat sir, Dr. Raish Gupta, Dr. Girish Bhatt, Dr. Akash Srivastav, and a special thanks to Dr. Gaurav Mogra for conducting the session. I also thank for our MPIAP team, especially Dr. Rajiv Singhi sir, and all the member of MPIAP who have joined the meeting, and the CIP member. EB, a special word of appreciation for all the participants who have joined the meeting. Thank you everyone for your valuable participation. Thank you so much.